All right, I'm Stefano. I am a professor of orthopedic surgery at the University of California, San Francisco, which means that I spend most of my time actually operating on people. I do hip and knee replacement surgery. It's really cool stuff. But I've also been interested in tech since the late 90s, and I have this role of the chief technology officer for the department. It's more innovation, but also run the digital orthopedics lab. We do a bunch of research I'll show you in a minute, and I founded the Digital Orthopedics Conference in San Francisco to bring people like you in contact with people like me so that there can be some cross-pollination, and we'll talk about how that can happen. So the outline for today is as follows. I'm going to define what orthopedics is, because a lot of people think it's podiatry. We're going to talk about the size of the musculoskeletal market and all the applications we're currently using that involve some element of artificial intelligence within this specialty. I want to talk a little bit about something I'm super excited about, and I'm sort of trying to get people excited about. It's about this sensor revolution with AI and the idea of perhaps bringing forward the concept of mobility as a vital sign. So orthopedics is a med-surgical specialty, focuses on the entire musculoskeletal system, all our bones, all our ligaments, all our muscles. It's the science of human motion. It's a massive market. It's one-fourth of Medicare spend. It is 10% of all healthcare spend in the United States, making it a $380 billion market, bigger than heart disease, diabetes, and cancer. And at least 30% of the population is affected by it. This being a young audience, who may be at 20%, but I bet almost 1 in 5 of you has some issue involving your musculoskeletal system. And it is a perfect lab for innovation. The reason is we're very high volume, and that volume is very expensive. There's a high margin associated with it, which means a small difference can have a big impact. Our cycle times are short, folks. Within 2 or 3 months, they've got you well again. We know the answer. It's centralized, it's repetitive and rules-driven, and it's image-focused. All great things for AI, and of course, the fact that it's global doesn't hurt. So Hinge Health raised $1 billion around the musculoskeletal market, one of the largest companies in the space right now, and obviously proof of concept that musculoskeletal is an interesting place to be. So these are the technologies that have been applied to orthopedics. Machine learning, obviously, speech recognition, computer vision, you can read them. And let's go over some of them, because 75% of all the investments in this space right now involve AI, and this is data we presented at our conference last year. The problem at some level is that within healthcare, we lag behind. And one of the things we lag behind is the fact that as we look at predictive analytics, we're still back here, we're trying to describe what's going on. We're not really quite at the point where we're doing optimization of data sources. This is a study I did a couple of years ago looking at a context that to us was very important, the thickness of articular cartilage in the femur. But without AI, we couldn't have interrogated 3,100 MRIs in a matter of hours and get the answer we've been looking for decades. Other papers, the ones that I read are ones that I published, looking at using machine learning algorithms and sensor data, or in the other case, X-ray, to understand if we can predict or understand what is in the data itself. But as I said, we're still at the level of understanding it. Very interested in synthetic data. We're starting to see it applied in my space. It is quite exciting to be able to amplify a signal to the point that we can shorten the trials and get to the answers quicker. Virtual scribes and ambient computing, another element of artificial intelligence, has taken off quite well. The problem here, and it was mentioned in the course earlier, is that it's AI that requires me to go back and look at it again. And I stopped using it. Even though I was one of the earliest adopters of these technologies, I just didn't have the time to go back and fix the algorithm, even if it was already reviewed by another human, because that human wasn't an orthopedic surgeon. So the idea of having AI that helps the AI, actually, as I was mentioning, yes, it's actually pretty good. Moving into the world of visual arts, if you will. This company I also work with, called Sierra Medical, looking at the use of holograms for the purpose of educating us, understanding what these structures look like before we operate on them. Also, VR is a terrific company, one of the best funded in the space, launched by an orthopedic surgeon who happens to be a gamer. And the concept here is you can actually go through the process of trying the surgery before you do it, and being shown that if you do that, your ability to execute is much, much better. Another area we're interested in is the use of gamification. This also in the virtual space. If you play the game, you essentially do your range of motion exercises for your shoulder, and this sort of technology is also starting to show up. augmented reality in orthopedic surgery is really hot. We can do crazy things like project soft tissue into the field of view, so the surgeon is working on a trauma and knows what the tissues are to avoid, the vessels and nerves. On the right, you see them actually placing a screw in a very specific part of the spine without actually directly looking like X-ray vision to the structure itself without using something called X-ray. To do that, I've actually tried this, and they're actually more accurate than if you try to use an X-ray. It's remarkable stuff. Computer vision coupled to AI tools can also be used for things like analytics. So you can actually have a camera track your surgery and then break it up into pieces and tell you where you've lost time, where you may be a little less efficient, and help you with that. Because for us, time is exactly money. This is a computer vision tool that couples AI with analytics and tries to track things like sponges and instruments and devices that may or may not get lost in the OR. This is another computer vision trick where the patient is in front of the camera and the camera is providing feedback directly to the patient as they're doing their physical therapy. And the holy grail, of course, is going to be some of these multimodal large language models that can take both images and text and try to answer questions on our behalf. And they'll be truly the co-pilot that everybody's been promising us, but as yet isn't quite there. Robotic surgery is probably the area of orthopedics which is growing the fastest. We get into something like, for some companies, 30–50% of their surgeries are produced using some kind of surgical robot. The way we do those is a little antiquated. We take a CT scan, make a three-dimensional model, do the work on the CT scan in a virtual environment on the computer, then translate that to the actual body. But before to do that, as you see me here, is putting a probe directly on the bone to tell the software, the robot where the bone is. This is really kind of old school. It's been around since the 1990s. I'm working with this company called RSIP Vision. We actually take 2D images taken orthogonally and create a 3D model with the same accuracy as the CT scan. Take that off the table. And then there's this other company called Advanced Scanners that can actually now use camera vision to take 1 million data points per second of a very small surface area and recreate the entire three-dimensional model of the bone if it has the CT scan to work from. Much, much more efficient than what we have now. But where we're really lagging is robotics. Now, to take you to what we have is a saw type of machine that goes on a plane. If you look at what Google was doing with their everyday robots, they were really programming for them for specific tasks and then using reinforcement learning to improve it. But you can see they made lots and lots of mistakes. And where they are now, though, is RT2, their Google DeepMind project that just got released, which is insane. It doesn't require any real actual programming. They don't teach it how to do things. It asks questions. Pick up the line, move it to next to the yellow flower. What happens is the robot, the vision language model goes to the web, figures out what a line looks like, figures out what a flower looks like. Then it uses its sensors on the robot to figure out how to move the lion to the flower, writes the programming necessary to make that happen, executes the command without ever having been told how to move a robot to the flower. And then if you ask it how to move that soccer ball next to the whale, it can do that and actually leverages the knowledge acquired on the previous task. So I think there's lots of opportunity for robotics to transition to orthopedic surgery. When you look at orthologistics, this is not specific to orthopedic surgery, but if you're trying to make a little money, this is where the money is, because we have so much opportunity in supply chain, resource allocation, process automation, payments, utilization, optimization. It's massive. And one company has done that well is Lean Task with IQ. They go into the software, figure out how to optimize your OR. A 4% improvement in OR efficiency can lead to $10 million in revenue for this hospital, $100,000 investment. That's good ROI. Where I think, though, it gets really interesting is when you start getting to confluence. I call confluence when multiple technologies or services come together to produce something that's never been seen before. When you have two rivers come together, the biology and the ecosystem of the second river, the complete river, is 4x what it was in the first two. It just happens like that. This is a soul machine. It's an avatar that can actually, it does have audio, but it's okay, that actually can use the camera and the microphone from your laptop and change its attitude, its speech, depending on how you're reacting to what you're saying. Obviously, a sort of take a Doximity-style ChatGPT, train on medical jargon, take that camera vision program we saw earlier, maybe add to it a little Amazon fleet of drones, and then attach all that to the Internet of Things, and you can imagine that you might be able to have something that looks like this. You guys ready with the audio back there?
Dr. Bini's assistant.
Thank you.
Hello, Sol. This is Tyler. I wanted to ask you about my recent surgery.
Hey, Tyler. I see that you had a total knee replacement 5 days ago with Dr. Bini. I have access to your records and can help you with any questions you may have.
Thank you, Sol. First, I don't remember what they found at surgery. I was a little out of it.
No worries. I just read your operative report and reviewed the visual records from the operating room. You had exposed bone on both sides of the joint and a torn meniscus. These are both considered excellent indications for surgery, so you can expect very good resolution of your symptoms.
That's great. The live XR was kind of cool. So, I'm glad it was correct. Also, the drone delivery with my medications arrived just as I got home, but I can't remember which pills to take or when. Can you tell me?
Yes, of course. The discharge summary states that you should take the pain medicine about 20 minutes before you put on your headset for your virtual reality meditation therapy.
And my leg, it's a little swollen as well. Should I be concerned?
First, let's run a thermal scan.
You have my permission.
Thank you. Voice print activation enabled. According to the scan, the skin surface temperature in tensile grade is not suggestive of any complication of a clot in your leg.
Okay, well that's super helpful, Sol. I feel much better.
Yes, I can see and hear that. Your anxiety measures dropped 7 points.
That's so cool how you can just see that. What else did you find?
You were a little behind on your knee flexion goals compared to other people your age and gender at this time in their recovery. You only achieved 100 degrees of knee flexion and are not putting enough weight on your operated leg.
Well, what do you think I should do about that?
I will send your results to Dr. Bini's office, as you might benefit from in-person physical therapy. I can arrange an automated insurance approval for the treatment.
Okay, well that makes sense. You have my permission. In the meantime, what should I do for exercise?
Voice print activation enabled. I sent the referral request and it was approved. We can review the exercises you should be doing, and if you can put on your rehab sensor shoes, I can help verbally guide your exercises.
Well, I like the idea, Sol, but can we do it a little later?
Of course. I'll reach out at 7 a.m. tomorrow morning.
You're kidding me, right? I'm supposed to be resting, remember?
Okay, fine. How does 9 o'clock sound?
That's much better.
Great. I scanned your home and see that you have a connected coffee maker. I'll set coffee to brew at 8:45.
Well, thank you.
All right. Acknowledging Sol machines for putting it together. That's available online if you're interested in showing that to people again. That is Confluence. Putting it all together, even your guys' product, into the mix to come up with what we're really looking for. That is what we're looking for. We're not looking at the pieces of it. Now, I'm going to change shape a little, because in there I also talked about this idea that the software knew that he wasn't walking fast enough or doing well enough. And the problem is we do not have normative data sets, nor do we have the data necessary to actually make that call. But if we can couple AI with motion sensors, we may finally potentially change the way we practice medicine. Let me see if I can explain that to you. So in 2021, I teamed up with Google, and we got a decent-sized grant to look at whether or not we could take machine learning algorithms and use the raw data from inertial motion sensors to replicate kinematic motion analysis, which we usually capture in motion capture labs, right? So that actually seems simple because people say they do it, but it's actually not so simple. But we're able to find the noise, the signal within the noise, and actually do that replication. And I'm going to jump over, but what that meant to us is that we can take the gate lab into people's homes. We have built an entire healthcare ecosystem on 3 minutes of data that we collect on people doing specific tasks in a lab, and have no idea if it actually is accurate when it comes into the wild. But we also realized that even if we made this software accessible to everyone and make it open platform, which is always the idea, if the sensors upstream were not standardized, the data collected wouldn't be accurate enough to push through. So we're working with CTA right now to create standards for IMUs to be used in motion sensor. Once we've done that, we can start thinking about this one. What is the goal of healthcare? All of it. It is to keep us moving. There is nothing else that's more important to us other than moving. Moving is what allows us to work, what keeps us away from predators, et cetera, et cetera. We can have a debate about this, but I will generally win that argument. but it's not a vital sign. We can't actually measure. We have no agreed to measure for mobility to track recovery, quantify wellness, avoid injury. But more interestingly, now that we have a confluence of technologies, the hardware platforms, the data monitoring, the low-power AI edge computing, and the cloud, we can start talking about creating mobility as a measure of outcome. Now, if we have a measure of outcome that's objective, you can start saying, especially if it's personalized and normalized, you can use it to assign value to any intervention in healthcare. You can also say, hey, if I invest this much money in this patient, how will it impact their mobility? Now, that allows you to change the equation for much of the way we care for patients, because most of the value is now on surrogate endpoints. They're not actually the final endpoint. It could be your blood glucose measures, which actually don't have that much of a correlation with much of anything if you play it out. So we're now looking to define a mobility metric. It's going to be something quite simple, something a bit like miles per gallon is to cars, a measure that we can use across the board and collect with some backup. And we're looking to meet with anybody who's interested to join a coalition of the willing and with the backing of CTA. We look at the application of of digital health and AI and technologies at my conference called Digital Orthopedics Conference San Francisco. We'd love to have any and all of you there. And so just as a summary, we went very quickly over what orthopedics is. It is a huge market. I showed you a bunch of applications quite quickly, but it's kind of fun. We talked about the AI sensor revolution and mobility as a vital sign. I encourage you to come to San Francisco. It's much cooler than Las Vegas, thanks to that fog. Come visit us. Remember, there are people who will ride the wave and be successful, and then other people who will go against the wave and we be swept away. And that's why I think there's a sold-out show today. We all know the importance of AI. The future is here. It is not evenly distributed. I'll make a quick pitch. I am traveling around the world visiting centers of digital innovation. If you're one of them and you like to connect, please let me know. With that, I want to thank you for your attention, and I hope you got interested in working in MSK space.